Welcome everyone to this last seminar of the year for the Behavioural and Implementation Science Initiative Center here at the National University of Singapore. Good morning, good afternoon, good evening for some of our international guests. I'm delighted. My name is Joanne Yoong. I'm a health economist here at NUS Medicine, and I'm particularly delighted today to welcome two of our guests who will be discussing with me the exciting topic of health economics and implementation science. So today I'd like to welcome, first of all, Dr. Hoomans, who comes to us from the Care Policy and Evaluation Center at the London School of Economics and Political Science. And we're particularly delighted also because Tees comes to us newly appointed to the board of implementation research and practice as an associate editor, where he also oversees the production of literature related to the topic of implementation science and practice today. I'm also happy to introduce someone who is not new to our Singapore audience, Dr. Shin, the head of health systems and performance at the National Healthcare Group here in Singapore, as well as adjunct faculty at GERI, the Gerontological Education and Research Institute here in Singapore, who will be also speaking to us in her role as an economist working at the intersection of research and practice. So what we'll be discussing today is really the different ways in which health economics and implementation science interact, what we see from global practice, what we see from the local context, and how we can move that intersection forward more productively. To frame this section, I thought we would start off maybe for this group here, because we have a very diverse audience here with us today, for which I'm very thankful, clarifying perhaps some of the definitions that we're going to be using, and maybe talking about what exactly we mean by health economics and what we mean by implementation science. And I asked ChatGPT. That didn't come up with anything very helpful. But let me just set the scene again by defining perhaps what we mean by implementation science. So implementation science, broadly speaking, is the study of how we bridge the knowledge action gap in evidence-based practice. The study very systematically of the strategies and science of getting evidence-based interventions into practice and policy. Now, that being said, implementation science here in Singapore, and again, those of you who have been part of our webinar series over the last year, is a field that is very rapidly growing. It's very much driven by the needs of policymakers and practitioners here on the ground, but at the same time has been growing, again, very much in parallel, perhaps, with the discussion of health economics and healthcare management. So one of the things I think we'd like to talk about today is how health economics informs implementation science and vice versa. For those of you here in the health economics space, what we understand to be health economics is a very broad, actually, array of questions related to the production and consumption of health and healthcare. And that means, as a health economist, that we consider effectively the choices and constraints of stakeholders across a variety of these contexts. We consider the stakeholders related who are our patients on the ground. We think about clinician choices, we think about policy choices, but we also think about industry, and we think about associations and civil society. It's a study of not just incentives on the ground, but also the resources and financing that we put in place to make those choices happen, and how we think about describing the outcomes of markets as well as planners, and perhaps influencing those choices as well. Within this broad house of health economics, one of the things that we speak about a lot here in Singapore is economic evaluation, which is a very specific application of health economics to try to understand and quantify again some of those choices that we're making in terms of the costs and benefits to payers and to society in general. And for those of you here from ISPOR, I'd like to welcome you. when we talk about health technology assessment and how health economics influences some of our decisions in that space. Again, that's a very real and concrete application of health economics, but health economics is more broad than that. In that setting, therefore, when we think about how health economics intersects with implementation science, a very important aspect of that is thinking about how health economics and studies of incentives and choices affects the way in which we get evidence-based implementations into practice. And of course, then understanding economic evaluation is part of that process as well. But I'd like to start this webinar by taking a broader perspective and maybe stepping back to that high-level question of how we see health economics more broadly as a wide discipline informing implementation science. And so to open that, I'd like to turn to Thies and ask Thies, so how do you as an academic researcher looking again at the broad field of health economics and yourself particular also from the field of management science, how do you see the ways in which health economics informs implementation science from the perspective of an academic researcher? Thies, maybe over to you.
Yeah, thanks for having me. I think it's correct to say that health economics does not just inform implementation science through the vehicle of economic evaluation. I think health economics and economics applied to healthcare in a more broader context can inform implementation science through improved methodology, theory, and observation. But before we get to that, I think it's something I want to highlight is that the way in which economics or health economics can inform implementation science is largely because economics in itself has made development, has evolved over time. So initially it started as let's say, traditional economics had quite rigid assumptions about how the different actors in a system and in a care system behave. They were assumed to know everything, have perfect information about goods and services, including treatments and medical practices and their evidence underlying it. And the market would work perfectly under a system of perfect competition. And economists over time have identified that in a healthcare context in particular, and you look into the work that Arrow has done, that those assumptions are not realistic. So the markets are not working perfectly in a healthcare setting, and just as well as the actors, the patients, the professionals, and even the managers and the policymakers are not perfect, rational human beings with perfect information. And therefore, there's been a shift there's been a change in how economics looks into that phenomenon of how people and organizations behave under scarcity. And I think this is also where implementation science comes in, because prior, implementation science actually had no role in a health economic setting, because economics would say any implementation that happens is actually meant to be there because the market allows it to happen, or it will resolve itself by itself. Mm-hmm. Over time, so what shall I go into some sort of specific methodologies that I think are useful?
Yeah.
What over time happened, particularly in the context of methodology, is indeed economic evaluation was brought up, but much more broader, in a broader set context, what was brought up is a structure for evaluation. So it identified the different variables that you need to look into in order to study the economics of implementation. And then there's models like Mason with colleagues at the University of York, who described a model of cost effectiveness, where they explicitly considered the effect of an implementation strategy on health outcomes to be affected indirectly to behavior change of the patient or the professional or the care organization. And it acknowledged that the cost of implementation would come at the expense of the care for patients. That work has been brought forward also by me, where we incorporated uncertainty that allowed more realistic, more rigorous evaluations of interventions in the context of implementation science. Another methodological advancement that I see that's been quite flourishing is quasi-experimentation, where you use natural experiments to set up studies into the cost effectiveness of or the effects or the cost of implementation efforts. Mm-hmm. I'll wait for you.
That was just me acknowledging and agreeing with you. But if you could give an example, that would be really great.
Yeah, so in terms of quasi-experimentation, there's this a famous experiment is there, the work by Finkelstein and others in the US, where they used the Oregon experiment to study whether or not the increased coverage of health insurance led to better outcomes and better use of resources in a care context. In addition to quasi-experimentation, which in itself is you're constructing an experiment. Another methodology that's considered very useful that came over from economics and that can be brought into implementation science is modeling in itself, and in particular, a new approach there is the development of synthetic controls. I see them go hand in hand because both use existing data and synthesize data from different sources in order to inform your analysis as to whether or not some implementation ever leads to better outcomes or better use of resources. Also there are a few examples. It's Naomi Crive, a former colleague at the London School of Hygiene and Tropical Medicine, who's been one of the first who identified the application of synthetic controls in the study of the effects of pay for performance on hospital care. Back to the economic observations, I agree that what economic evaluation is still a very useful vehicle to inform implementation science and the study of the economics of implementation, but it's still, and various reviews have shown that over time, including recent reviews by Reeves and by including work by Inola Proctor, is that economic analysis of implementation strategies are seldom done, let alone that economics has influenced implementation science in such a way that we're already observing, even though we know we're studying the behavior of individual patients and care professionals in the care system whose behavior or choices need to be changed, we seldom study their economic activities in the sense of, do we study the time that they spend on care, the time that they spend on learning about new methodological advancements and so on. And we seldom do that. The final advancement, and then I'll close for now, is the theoretical achievements in economics, where indeed we came from assumption of rationality and perfect market working, where we now enter into a field of behavioral economics, where we acknowledge that individual actors don't behave rationally, they have imperfect information, they interact with each other. There's also evidence or case evidence about the idea has always been that you need to incentivize in a very bureaucratic manner, and that leads to perfect behavior of actors in a care system. What's now increasingly being seen is that if you let groups of patients or care professionals develop for themselves rules of behavior and organize their resources, they do actually pretty well. So I see, in the context of how economics or health economics can inform implementation science, three ways: methodological, in terms of observations, and in terms of theoretical achievements and contributions.
Okay, perfect. Thank you so much, Thies. I was going to say that, when you describe the perfect decision maker who basically assumes that they have all of the information and put things into science, I think, we often in ourselves, in our healthcare system, are very overconfident about what goes into the healthcare system. And I think, again, the paradigm of economics is a very long lesson learning process by which economics has learned that putting things into place simply because we think that they're going to work in theory doesn't mean that they're going to manifest in practice. And so, as you said, the field of health economics today is really important for implementation science because it helps us design better implementation, taking into account realistic behaviors and choices of the actors. It's helpful in methodology because it helps us empirically do a better job of measuring some of those things. And last but not least, at the end of the day, the economics of measuring implementation cost is something that we are only now starting to put into place in addition to everything else. So I think these three aspects are really key for us. I'm going to turn now to Woan Shin and ask Woan Shin, from the point of view of someone who's full-time job here is actually making action research, something that's practical and connecting this to people on the ground. How do you see health economics in practice, in interacting with and informing implementation science? Again, from the point of view of someone who is seeing this on a daily basis, and not in theory, but really as something that has to be done. day by day with the various stakeholders that you interact with?
Yeah, thanks, Joanne. Thanks, Tees. Thanks for setting the stage to describe the intersection between health economics and implementation science. It's not an easy job. Both are two very big topics. So thanks for setting the stage. So I always believe that context matters. So I will describe a little bit about my personal experience, right? So at least some of the things that I say later on make some sense, right? So I came into health services research as an economist, not a health economist, as an economist. And I started off by studying the quantitative impacts and the cost effectiveness of programs. I think quite similar using methodologies that Tees mentioned, right? Quasi-experimental studies, propensity score, instrumental variables, things like that. But as I was evaluating these programs, right, it was challenging because I could only offer hypotheses to explain what resulted in the outcomes. So being a very practical person, I started to pick up qualitative research. That was during my PhD. And then subsequently, I was involved as an evaluator in several implementation evaluation projects. So I thought I was quite happy to have different tool sets at that point and to be able to have a holistic picture of the evaluation results. But, however, the next thing I realized was that translating those findings into practice was yet another hurdle. So that was another story, right? So through my work at actually the Geriatric Education and Research Institute, I began to learn about the science of knowledge translation and implementation science. So that was both fascinating, exciting for me, and it's also quite a relief to know that there's a science behind how I could translate some of these findings into practice. So how I came into that intersection of health economics and implementation science was quite different. It wasn't through a theoretical lens, or it wasn't through a course that I did in school. I actually started to appreciate the role of health economics in a very practical way through my interviews with people who are running programs on the ground. So as an evaluator, I was talking to different people about their implementation experience. I will use one example. My own research work centers a lot around geriatric and end-of-life care populations. So I have quite a lot of work in the area of advanced care planning. So I use that as a concrete example. So in our local context, if you do not know, advanced care planning is basically a facilitated discussion, right, that occurs between someone who is a trained facilitator with the patients and their loved ones. And what happens during this discussion is that we discuss the values, the beliefs, and then we go on to define end-of-life care goals and preferences. Right, so for a traditionally trained health economist who's looking at the cost effectiveness of this intervention, I'll be very focused on the intervention itself, which is a discussion. And this discussion, based on what I've been told, averages between 1 to 2 hours. It can go on for multiple sessions as well, but on the average, it's about 1 to 2 hours. So if you think about the cost of the intervention itself, it doesn't seem to be exorbitantly high, right? However, during the process of talking to the people who are implementing this intervention, it was quite interesting. They started to highlight to me, so what do we need to do? We need to appoint champions. We need to train members of our staff to be able to do this. It doesn't sit nicely within our workflows. I need to redesign these workflows. Family and patients do not know anything about advanced care planning. I need to design materials and reach out to them. And also we need to set up new clinical processes. So coming into this as someone who is trained as an economist, I started to reflect. And I realized that what they're actually telling me is about the resource implications, right? The things that you need to actually implement this new thing called the advanced care plan, right? And not just the intervention cost itself. Traditionally, cost effectiveness analysis are very useful, right? We talk about incremental costs against the benefit of the intervention for resource allocation purposes. But yeah, at the same time, I think when I first stumbled into this insight, I don't think there was a very good way for me to start thinking and tabulating implementation cost, right? But I do know that in the recent 1 to 2 years, a lot of papers have been published around this area to provide guidance on this. And I think there's something that's important for us to capture. So I did take a quick look in literature before today's webinar. I think less than 10% of implementation studies included information about implementation costs. And I think this is very important. And this also sits very well for me as someone who's working in this real world situation, right? In working with people. So some of the things in terms of ascertaining this implementation cost, it also leads us to answer very practical questions, right? Questions that our finance departments may ask us, questions that the program leaders will need to know, right? So do we need additional budget to implement the service? I think in the case of the advanced care plan that I just gave, the short answer is yes, and pretty much there's quite a lot of different resources on top of the implementation cost that needs to be considered. And I think many of us who work in the healthcare setting know that not everything is budgeted for, right? So there's a lot of hidden costs here and there where people, existing personnel, right, are spending their own time or maybe time away from other tasks that they are supposed to do to come together to design, plan, and implement a new service. So the next question is, will this hidden cost, right, tapping on existing personnel affect implementation of the program if we were to move to a different site, right, that operates in a slightly different manner? All these resources need to be carefully accounted for. And the next thing we also need to think about from maybe a cost effectiveness lens is we can't maybe use the same way of looking at cost per quality, like cost per quality adjusted life years. What else can we measure by? I think one very practical thing that we always get asked when we sit in for discussions with implementers and funders and finance colleagues is that how many more patients will be served, right, if we implement this program? And what is the average cost per patient? So this gives us some idea of how to go about, even while using a cost effectiveness framework, to think about implementation costs. And I think T's mentioned, right, we also get asked, can we know the cost? Can we simulate the outcome of different implementation strategies before we even start the program? And I think we have done some of those work, but few, because you do need quite a lot of expertise coming together pre-implementation, right, to think through the resources required to inform the implementation strategy. And I think the last thing I will just mention before we go on to the next topic is that I work a lot in the field of geriatrics. So I think when we think about cost, implementing newer projects in population health, the family unit plays a very big role. So in terms of cost, we must move away from health system costs, because a lot of programs may rise and fall as a result of that incremental cost that's accruing to the families and the patients when they introduced to this new program. That's all I have for this part.
All right. Okay. Thank you, Shin. And actually, that example, I think, really resonates a lot with me. I think I would also contribute. I think that in practice, we've also seen the way that health economics actually can contribute in many different ways to a project, but also that it is limited in some ways as well. So, for example, in work that we have done looking at vaccination, a health economist is very helpful in designing financial incentives. And with behavioral economics, we know that there are many different ways to design a financial incentive: upfront, over time, fragmented, paid to X, paid to their family. All of these different things are part of how behavioral economics has contributed to incentives that better nudge patients, right? And we know that we can look, therefore, at better ways to make incentives that are as part of an implementation strategy informed by the new science of behavioral economics. Then we can use economic evaluation methods to look at how this works. We can look at modeling and simulation of the long-term impacts of vaccination. And so really health economics can come into play at all of these different parts. But at the same time, we need other implementation science-related outcomes to be measured. We need to understand if vaccination is appropriate, if this is feasible in the community, if talking about financial incentives is appropriate for the communities that we're talking about. Does it make sense? Is it going to be acceptable for example, older adults in this particular area? So it's a very powerful tool in many different ways, but it is also something that needs to work hand in hand with implementation scientists from different disciplines as well to make it happen. I'm going to also just take a quick pause here and say that we have already had some questions coming in from the floor. I strongly encourage our audience to ask more questions. There will be a Q&A session coming up, so please bring them into the Q&A box. I'm very excited to see a number of these coming up already. I'm going to turn now back to Tees and say, speaking again about all of these collaborations, what do you see as some enablers of the relationship between health economics and implementation science? What are some use cases where we've seen this work well? Where do we find that, at the end of the day, these are situations where that collaboration works better than others? Or what can you tell us again from the global context? Where have you seen this well facilitated?
Yeah, I think it resonates with what Shin said about where it resonates best is where let's say the target of research or the target of implementation and those working with you in research projects are aware of or knowledgeable about the economics of what it is that they seek to, about the economics of the change in behavior that they're expected to do. So they are, to some extent, if you get to the example of Woan Shin, the families need to know what it means to them in order to change how they get care from there on. That in itself is also a burden onto the health economics of the intervention in itself. So we talked at the beginning, Joanne, you said we're talking about the implementation of evidence into practice, and the question there is, of course, what kind of evidence? Do you go as far as just assessing efficacy, effectiveness of treatment, or you go into cost effectiveness of treatment, or do you go even further into the acceptability of cost effective treatment for a family in some place somewhere at some time? And that's where you start off. Facilitate in implementation work and implementation projects and in the incorporation of the health economics in there, so particularly in the context of measuring resources spent or time spent on making sure that you know about the latest care, is when the individual you're targeting with either the research or the implementation effort is well aware of how that might better inform decision making. So a concrete project I've worked on, for example, is when we studied, and I consider that an implementation strategy, where we set up a quasi-experimental evaluation of team-based care, where the idea was if you group health and social care professionals in a team, they start to work better together. And initially, it was difficult. A full study would involve many, many layers. So you'd need to go all the way to end outcomes, into the individuals with care needs being helped better and their care experience and the quality of improved quality of life. But you recognize that improvement in the service that they receive is through better working together of those individual care professionals. So you need to also assess in them how they start to think, at least, how they work better together. So that required information collection, economic information collection in them about their information exchange, communication, shared decision making. And then you develop a model by which to improve the information exchange, communication, shared decision making among care professionals that would lead to improved outcomes for individuals with health and care needs. The team setup and the launch and the resources being provided to the team was at the higher management level. So you need to incorporate all those stakeholders in the design of the study, but also not in the design in itself, also in the potential use of the results of that information. If any stakeholder in that study is not on board with what you seek to accomplish, they will not provide information. So I actually think that health economics and economics in itself, if you explain that to people, I do that in my teaching as well, if you explain them what economics is all about, is that it's all about you facing and contemplating decisions in your daily life where you seek to live or improve your life with the resource you have available. And at any stage you face a decision, you want to make the best decision, economics is there to help you. That's it. Can be still incorporated with social insight from psychology, sociology, and so on. But I think that's still the biggest facilitator, that educating of people about what economics or health economics involves. And on top of that, what implementation science might involve. I think we're going to talk about setting up multidisciplinary teams of research. That will help as well, right? Building capacity will help as well in study sites, whether it's an implementation site or a study site in itself. I work on an NIHR project in the UK where we study the implementation of social care guidance into policy and practice. And the beauty of that project is that there's some funding support or some funding to support capacity building local sites. That's a huge vehicle to economics research or implementation research at the sites, not just because they get an incentive to do the work, but also they start to learn about what actually could we get out of the research and how can we design the research in a way that's actually leading to good outcomes. I agree with what Woan Shin said earlier. When we say we still know very little about the hidden costs. And one other vehicle I see is that we need to improve more or develop more practical approaches to observation. And with that, I mean, to how can we actually get information about the hidden cost of implementation by, for example, predominantly frontline workers, individuals in society and their carers. Do we need to do diaries, time motion studies? But if we were to do that, how often and how big should the sample be? Can we develop more practical approaches to that? You know, I see now that there's technology available that might facilitate us in our research. And I also agree, and that gets back to what Woan Shin said as well. At some point, when you do health economics in the context of implementation science, you have all the stakeholders involved in improving your care system, from the individual needing care to the frontline worker to the care manager to the commissioner to the policymaker. I think also a vehicle to enhance the use of health economics implementation science is to really start to think about that policymakers or care organizations need to really start to allocate implementation budget, even if it's just for the sake that you acknowledge that care provision does not only require you to invest in your intervention, in the medical treatment, in the diagnostic instrument, in the or whatever, but it requires investment in making sure that the treatment gets there. And that in the context of economics, decisions need to be made. Okay, I have a limited budget. Not everything will go to medical treatment. A part of it has to go to making sure for whatever outcomes we seek to achieve needs to go into implementation efforts. And that could be if you want to improve quality of life for your entire population. But it might also be, and this is where it gets more tricky, because you want to create more equitable care. And how are you going to weigh into that? And who's going to then bear the cost of making sure that care is more equitable? Is it to the group of people benefiting from equitable care, the disadvantaged a priori, or is it the entire society and population?
Yeah, I think that's a huge question here for us here in Singapore. And I also think that, it really resonates also with me, because a lot of times when we roll out projects, I think one of the things that we really forget about is opportunity cost, which is a very fundamental question for economics, right? So people, I think one of the problems that we have often as economists is that people confuse economists with accountants, and they try to sort of say, I would like you to come in here as an economist and just count the costs as comprehensively as you can. But fundamentally, what we're trying to do as economists is help people understand that firstly, we want to look at the incentives of everyone that's involved in the collaboration, the costs and benefits to all partners, hidden costs, intangible costs, as well as resource costs. And that's really what drives decision making. But also, what else could you be doing with that time? And an economist is acutely sensitive to that, whereas a lot of times our cost effectiveness analysis sort of live in this vacuum of abstract space. And I really appreciate, again, the question about saying, we need to allocate budget for this implementation of interventions, evaluation of interventions, and then creating systems that actually feed that knowledge back to decision makers in a very practical way. And actually that leads me to Woan Shin, in the local context, what kind of enablers do you think you see or would you like to see to make this happen? What do we need to see, especially with all of the things that are going on today in our healthcare landscape? What do you think we need to see in order to make this happen?
I'll start with the point that you ended off with first, then I'll talk a little bit about other things that I've been thinking about. I think a lot of us are, we turn out in meetings and there's like 20 of us in a room. That's the cost. Yeah. I mean, Joanne is laughing because that's normal, right? But I think maybe as a practice, we need to start to understand and recognize that there's a lot of cost to design and implement a project at the conceptualization phase. And that's something we need to start setting aside resource for, right? Because if not, you run the risk of under-resourcing further expansion of skill-up efforts. So that's one thing that I think I would like to highlight for the local context, that we need to start thinking about things in that way. And then the second thing that I think that I'd like to talk about is actually what Tees also mentioned, really having a same language, I think. Implementation science is quite new to me. I really started getting, understanding it and getting a bit more involved in the last 2 to 3 years. So I think as I'm going around, people don't quite understand what exactly it is. And it gets more complicated when I try to explain how is health economics within implementation science different from health economics within health services research. Right. So I think continued conversations, education, sharing platforms like this is very important, right, for us to have some form of collective understanding so that we can move forward. The other thing is to find an economist who knows health economics and also have knowledge of implementation science is also a challenge locally. Right. So for myself, I did, it was not that intuitive. I had to read up quite a lot. I went for some courses to better understand it. And to be honest, there's just not enough economists going around. So I do think that going forward, some of the things that we can do that I've been involved in is cross-training other members of the team to at least have that lens of health economics lens, and maybe some of them to be able to do some of the work that's involved in it to try to move this forward. Some enablers that I've seen that has supported the growth. One thing is really that's quite heartening to see the growth of the research centers, right? And so different researchers now focusing on implementation science that is pretty unheard of maybe 5-6 years ago, right? It was new then. So I think that's good because having a critical mass of educators and also researchers is important. And the next thing is, I think I mentioned earlier that in the last couple of years, there's been a movement and publications about the methods in particular to the application of economic evaluation within the field of implementation science. I think for me as an applied researcher, I really welcome that, right? It was challenging when I realized that I need to distill implementation costs from intervention costs and subsequent costs. And having some guidance, around how to do that, it was very useful for me. And I really look forward to using some of these frameworks. I will briefly mention what these frameworks are. I think maybe the audience can pick up and Google for it if they are interested. Right. So some frameworks like the stages of implementation completion process model. There are also cost mapping tools like the COINS, cost of implementing new strategies. And also some paper, I think by Tees, that talk about how do you look at costs according to the stages of implementation. I think all these papers are very useful for us to take into consideration when we are moving to incorporate health economics within implementation science. I think the last point I'll talk about here, actually in relation to your question, is that quite heartening, right? In the recent conversations I've been going to, funders are starting to pose questions about the effects and the cost of scaling up interventions. And this is the cost beyond pilot and demonstrative phases. So I sense that there's some urgency, driving the local administrators and policymakers around how do we go about scaling up clinical programs and intervention to benefit a wider population. So I think this is great, but I think at the same time, we also need to be mindful that the speed at which it progresses, right? It can be a double-edged sword because once something is introduced, these investments can be difficult, right? Yeah. That's something that has happened many times before. So I think as a science, we need to start designing implementation strategies alongside effectiveness evaluations, right? To really be certain we don't have the time to do it sequentially. Probably need to do everything all at one time so that we can meet these, real world demands that's being asked of us at this moment. Thanks, Joanne.
Yeah. Thanks, Shin. I think that's, first of all, this is the first time I've ever heard anybody say finish the sentence, funders are asking questions. This is a very hopeful development, but okay, I'll accept that. I actually like to pick up with that and actually move into some of our audience questions. And I'm actually going to turn this back to Tis for a second. And one of the questions are really about implementation frameworks. I think, Shin, thank you actually for introducing some very concrete implementation frameworks for the audience. Some of the audience Q&A are actually very interested in specific frameworks for other aspects of these questions. So one of the questions are, when we think about then organizational readiness around evidence-based practice and taking that up, right? Are there implementation frameworks that should be used to actually, even before we get into thinking about implementation costs, to think about prospective costs? So are there frameworks that we should use to assess organizational system readiness? And then the second question about frameworks is, to what degree are these adapted, for example, for different cultural aspects? So we've talked a little bit about how behavioral economics tells us that, this purely rational, very objective, very above it all decision maker doesn't really exist. So do we have implementation frameworks that also account for some of these irrationalities or biases, but also particularly cultural differences in how people might view specific costs or specific implementation strategies? So those are two questions, I think, about new types of frameworks that we should be considering: organizational readiness, but also cultural and individual factors affecting decision making.
Yeah, I think that's a very, very good question. And that also relates to another issue in terms of technology development and early stages of making decisions regarding allocating resources to improve care in the system. Is indeed that if you innovate in care, or you develop a new medical treatment or intervention, what implementation science does and has done, and what also organizational management science has done, is already identified that there are factors at different stages of the care system that can influence the uptake or the implementation, the ease of implementation of that new innovation. One of them is indeed organizational readiness. If an organization, whether it's a hospital or care home, doesn't have the resources, doesn't have the political leadership, or the management in place that says, I'm happy to adopt the innovation, it will not happen. That's one. I on the top of my head, I don't know. There are frameworks for that. I can't just mention one right now. Similarly, there's also, it's not just organizational readiness, there's also frameworks for, and if you look into Implementation Science Journal and you Google organizational readiness, I think it's by people like Weiner or Damschroeder, Powell. They've brought forward this kind of work. But it's not just organizational readiness. It's also a more specific thing, and that may relate to cultural differences in organizational context. But there's yet another thing, is implementation climate. So you can be ready as an organization to adapt to changes, but you can also be an organization that's innovative or less innovative, right? So there's two layers in there. Then there's the layer of the technology in itself, and implementation science or also other sciences have already identified, depending on the characteristics of the new technology or the new medical treatment, it's more or less likely to be taken up in practice. If it's very complex to incorporate into your daily practice, it's less likely. If it's triable, so doctors can use the medical treatment for a period of time and see whether it really works in their patient population, it's more likely to be adopted. If the benefits of the treatment are quite quickly observable, more likely to be adopted. Those are factors: organizational readiness, implementation climate, technological factors. Then, of course, and then we get into that aspect of cultural changes. You still have people. Economics is very clear about that. It's all about the people and the actors and the organizations as individual actors. You have people who may be more or less keen to innovate. And I don't know how that differs between cultures. In some cultures, so the UK has a very established NHS system where there's a certain way of working, which you might say is less keen to innovate. I'm not sure that it applies in all circumstances. In Singapore, it might be yet differently. I'm not sure it's about the culture in itself, whether you then talk about the culture of the system, the culture of the people in the system, the culture of the patients. the diversity in the patient. So it then gets very tricky and very complicated, but that's actually a very cool task for implementation scientists to study, identify. I'm not sure whether cultural difference matters so much per se as the key ones. The bad thing about implementation science in the way in which they studied implementation strategies, and which may also relate, which may make you a bit more skeptical about the application of all these different frameworks, all these different things. I think for 20 years or so right now, they've always said there's no magic bullet as to. So in economic literature, it's the same. You don't know whether technology will diffuse or not. There are some patterns being identified that with early adopters, and then middle people who accept followers, and then it wears off. But implementation science has done the same. They still don't know yet. It's partly because it's maybe at the early stage, and partly because we start to identify that if we talk about implementation and its economics, we are considering many variables that might be of influence in the way in which technology diffuses, gets implemented and adopted in practice. All those components work together, from organizational readiness, implementation climate, to technological factors, to people in the front line, care professionals as well as patients, and their cultural differences. We're yet to find out, let's say, almost a minimum set of data on which we could collect minimal set of data variables on which we could collect data across different organizational settings or care systems to start to identify whether or not culture matters. Or what it is.
Yeah. So we don't have, I think what I take away from that also is that, we don't have all the answers, but some of these answers are not fixed answers, and actually coming up with a set of very pat answers is probably worse in different contexts than saying very honestly that we have to work those answers out depending on what we see. And I think this comes back a little bit, slightly indirectly, to what Shin was saying, is that one of the things that we are doing today is we're sort of building the ship as we are sailing it. And part of the problem is that we want to make sure that while we provide the right information, we also don't want to go out there and do something that is misleading or based on an inappropriate framework. So I think part of that is still reflective of how the field's moving along. Shin, I'm going to ask you two questions, actually, in one from the chat. And the first question is actually, on the ground, how do you really, given that this is an evolving conversation, it's a difficult question, and we don't always have all the answers. How do you actually effectively engage stakeholders to talk about implementation costs? How do you actually get people started on this conversation? I think Tees had already said before that part of it is really sort of framing it in a way that's accessible and very connected to people's direct outcomes. But how do you approach that? And also, how do you think that if we got this conversation going, and I know this is a little speculative, how do you think then that our program landscape would change? So what if we actually got what we
question? I'll answer it from the point of view of a mixed methods researcher. Sure. Actually, the quite interesting thing to me is that I think in the beginning, when I started doing cost effectiveness analysis, I was asking people to fill out maybe survey forms on the cost and the tasks that they're doing. But then as I started to interview people, I realized that the program has its own evolution, different stages of implementation, and people are telling me quite precisely what they're doing. If it's a longitudinal, I had a longitudinal study before, so I talked to them at various time points. A recent study that we completed actually talked to the program implementers over 3 time points. But the unfortunate thing was that it's only through the experience that I realized that I could have embedded a health economics perspective within that conversation. So I do see that I could interface qualitative interviews, right, and still use some of our traditional economic data collection methods, right, to try to ascertain the implementation cost. So I think what doesn't work is if I call them all into a room and tell them, let's talk about implementation costs, they will not be able to tell me, because part of it is experiential. It's by trial and error. They try this strategy, doesn't work, they change to something else. And we need to have a process that captures that. Of course, non-participant observation sometimes does help, but of course, that's resource intensive. So how will it, your second question is how will it shift?
Yeah, so if we actually manage to get this going, we get these discussions going on, how do we think that, the funding outcomes would change, or the program what would really change? So if we really succeed in, fostering this collaboration, then what then?
Yeah, so I've been thinking about it. I think a lot of times programs are unable to scale, right? It doesn't boil down to a single thing, but implementation costs and also financial barriers faced by patients and their families, and also the lack of financial incentive to change our behaviors, non-monetary and non-monetary incentives to change our behaviors come into play. So if I were to just talk a bit more specifically about the implementation cost, I think it will give us a greater sense of the real resources that is required for us to move from a pilot to a scaled up phase. Because a lot of times, right, these costs are hidden in a pilot phase, and people are trying to get by with the bare minimum budgeted cost that they have to run the service. So by making this apparent and explicit, it will help to try to for us to translate things that are evidence-based into practice.
Yeah, I think that's really informative. And I think, one of the questions, if I may, in the chat is, what would happen if this happened in real life? And I think it would also be the case that we would see that on the ground, healthcare workers, clinicians, and healthcare professionals be a lot less frustrated. Because today the answer is, oh, we didn't budget those. You are the implementation cost. Somehow you will make it happen. And the fact of the matter is that we are juggling, first of all, the quality of projects hopefully will improve. It's not the case that any science has a perfect answer or it's going to perfectly predict the outcome of a project. But I think a lot of the invisible burden on implementers on the ground right now hopefully will be acknowledged and relieved, and we'll have a little bit more of a rational way of getting innovation into the ground. So better quality of projects, but also less tired and underappreciated people. Okay, we hope so. Okay, I'm gonna say that we have only, I think, 5 minutes left of this chat, which has been just a fast. I don't know where the time has gone, but I would like to actually turn this back to Tees and then Shin to you for the closing remarks, and just ask Tees, what do you think? What is the most exciting thing for you in this area? What are some developments that you're looking for? Just very briefly, what actually makes you most hopeful about this field?
Oh, hopeful. That's another thing. But I want to add to that question about when we start to discover hidden cost of implementation, where I believe that they lie at the level of at the frontline care level. Indeed, we start to identify that care workers, care professionals, as well as individuals seeking care and needing care or receiving care, are the ones who carry the current burden of cost of implementation. And I like for us to be able to find practical approaches. It's also something I look forward to measure or to get hold of those costs. And I think the way in which it will change the research agenda is that, or the resource allocation agenda, is it put much more choice power there where it needs to lie, I believe. And that's where the care really happens, at the patient level or individual level and at the care worker level. There's also a beauty in there in the shift of the agenda is that I believe a very big goal for implementation science is not just to improve efficiency in a certain way, but actually to improve equitability and equity. So if you start to dissolve or identify hidden costs of implementation, what you will find most likely is that those less advantaged carry much more burden of making sure that they get the treatment that they deserve at the right time, in the right moment, in the right conditions. That's coronavirus has shown that, for example, as well, that those disadvantaged were much more harder hit by the effects through many layers, whether it was through prevention, to whether the living conditions, to having access to care, or to having access to coronavirus treatment. But you can think of many ways in which it will happen. But something that really excites me when we think about the intersection of economics and implementation science is work developed by Hurwitz and then further advanced by Meyerson and Meskin at the University of Chicago, is that idea of reverse engineering. And reverse engineering is very simple. You go back to the core of what economics is. It says it's a care system with limited resources, with multiple actors in there who all have to behave in a certain way to maximize outcomes. What you first want to establish is, what outcomes do you want to accomplish? Reverse engineering starts there and then works backwards to identify how do we design our organization and the organizational arrangements and the incentives in a way in which we actually maximize the likelihood that we achieve that outcome. That's different from pushing the innovation forward and hoping it will land somewhere and it will benefit some. I'm excited about that. It aches to work in the context of operation research, normative microeconomics, and that kind of stuff. It's really cool. What on top of that needs to be done is that we then talk about the mechanism by which change happens. We need to get much more research done in the area of these organizational processes that govern how the different actors in the care system behave and interact with each other. How do they exchange information? How do they communicate? How do they share decision making? We need to still develop constructs by which we can assess those processes and measure them and get a hold of them, because that will be a very important aspect of, at least from a managerial point of view, a policymaker point of view, an aspect that you can start to tweak and make sure that they go in the right direction, right? Mm-hmm. We always aim for the final end outcomes, improved quality of life, better outcomes. But in between is that black box that is still very much unresolved, where there are processes involved and dynamics where the policymakers, the managers, the care professionals, the patients interact through certain processes governing their interaction. And we need to get hold of that. That will also support reverse engineering. And I find those two aspects the things I look forward the most to work towards, to collaborate on, and etc.
Yeah, I think that's terrific. So basically, what I really like about that is sort of saying, we start off that we have a shared purpose and we articulate that shared purpose, and then we try to operationalize this in a very concrete way, and that's what makes it go forward, right? And that's really, I think, why we are all in the area of health. It's a complex beast of a system, but we need to start off with where we want to go and what we want to do together, and then try to work out how, but in a very scientific and measured way. Shin, I'm going to turn to you.
So from the research angle, I'm quite excited to be involved in a couple of new projects, not funded yet, grant ideas, designing studies using hybrid tool design. So we simultaneously test implementation strategy during an effectiveness trial. Personally, I've not done that, never been involved in it. So quite excited that there's a group of us who are working towards that. And I think the other part that I spoke about was really the use of qualitative methods, right, to support costing approaches to get to a better estimation of the implementation cost. So from the research angle, these are the two things that I'm quite excited about and looking forward to. And from the practice angle, I think it's really that I think over time, my role as an evaluator has sort of evolved in a way that's intentionally built to be that way. So what happened in the last couple of years with some of the projects we've been on is that we intentionally position the role of the evaluator in between the implementers and the policymakers, such that the knowledge translation and any redesign, co-design that occurs during this process occurs throughout this duration of evaluation. So we no longer wait until the end, right? So we create platforms for discussion and stuff like that. So there's more immediate feedback in a more, quality improvement approach to things. And the other thing that I'm excited about from the practice angle is that I'm currently involved in a knowledge translation platform that is related to advanced care planning. So in the past, 6 to 7 years, there have been two pretty major evaluation projects that's being done looking at the implementation of ACP. So from those two evaluations, we understand to quite a good extent the barriers for implementation. So what this knowledge translation platform seeks to do is to utilize implementation science approaches to identify these barriers and to identify strategies in order to test them out in real life and see whether it helps to address those barriers. So these are the two things from a practice angle that I'm very excited about, and hopefully something good comes out of it. Yeah, thanks.
Yeah. Well, I'm very excited. I hope something good comes out of this. So I would like to just say, if there are any funders in the audience today, please be aware that Shin has two excellent research ideas that are not funded yet. So please pick this up as well. But I actually I'm very excited about that. And I think the nice thing that you mentioned there is that working hand in hand with people to give feedback on an ongoing basis as part of a learning system is so important. That we have to get away from this paradigm where health economics comes at the end of a chain, everybody's done with something, and then they throw this at you and say, well, is it cost effective now? And we work in this vacuum, which makes literally no conceptual sense, but also is not helpful. That health economics is a silo. Implementation science is at the beginning, health economics at the end. That is a paradigm that needs to be completely broken, I think. And it is unfortunately a predisposition in the way that we have worked before, but I think it's a brave new world for us, particularly here in Singapore. We are going to be living through a very exciting period of healthcare reform. There's lots of room for everyone to participate in research and for research to really inform some of these changes. So I really want to thank both of you for being here with me today. Thank you so much, Tees, for your experience and for your being able to bring us to a very high-level discussion of what this really means for the field. Thank you so much, Shin, for telling us what that looks like from the ground. I'd like to thank our audience for the great questions. I think one of the real comments I'd like to pick up from the question and answers that we have one colleague who actually mentioned that healthcare economics is exquisitely local. And I would agree with that. I like the phrase exquisitely local. But I would say that there are many things that we can learn from our local experience to enrich science. That's how science is built up, by the amalgamation of local studies into something more general, and at the same time to learn from something more general and bring it to the ground. So thank you guys so very much. This is the last webinar of our series. Thank you all for having been with us this year, and I wish you all a very good rest of the week. Thank you.